Hello, my name is Nathaniel Starcher. I'm a third year medical student at OU HCOM, and this presentation is going to be over reversing the approach for reverse shoulder arthroplasty, a comparison of the deltoid split and deltopectoral approaches. Here's a quick table of contents of the layout of this presentation. Reverse shoulder arthroplasty involves removing the proximal humerus and glenoid from the body and inserting a prosthetic device instead. Has many indications, but for our study we looked at fractures, specifically a 3 to 4 part proximal humerus fracture, which are common in the elderly population and are expected to increase as the U.S. population grows older. Previous studies have called for treating proximal humerus fractures with open reduction internal fixation. However, arthroplasty is becoming more and more popular due to better clinical outcomes and reduced complication rates. Of note, we are looking at reverse shoulder arthroplasties, not a traditional total shoulder arthroplasty, which means that the cup in the ball and socket joint alignment has been reversed to where the ball is actually sitting on the glenoid and the cup on the proximal humerus. And why we do this is to basically increase the moment arm of the deltoid muscle, as described in the images below. I liken it to pushing on a hinge door from the part closest to the hinges and then trying to push on the part furthest away from the hinges. And it's obviously a lot easier, and you can generate a lot more torque from pushing on the part furthest from the hinges. Surgeons often choose between two main approaches when performing arthroplasty or and other surgeries on the proximal humerus. The first is the traditional deltopectoral approach. The second is a newer deltoid split approach. Recently, randomized control studies have shown no difference in the intraoperative and clinical outcomes between these two approaches for open reduction internal fixation of the proximal humerus fractures. However, to the best of our knowledge, there has been no study looking at these two approaches and for reverse shoulder arthroplasty. It is our hypothesis that, therefore, the deltoid split approach will have similar intraoperative outcomes, patient-reported outcome measures, and complications compared to the deltoid pectoral approach. In this study, we did have a significant increase in BMI for those that underwent a deltoid split approach versus the deltopec approach. However, there was no other statistical significance found in these demographics. Our study was a retrospective chart review from patients pulled from a level 1 trauma center. And after inclusion and exclusion criteria were enforced, we ended up with 29 patients that fit for our study. They were divided depending on the approach that was used, 16 in the deltopec and the 13 in the deltoid split. And of these, we then performed patient surveys and analysis of operative and post-operative outcomes and complications. Table 1 shows that those in the deltoid split group spent a significantly less amount of time under anesthesia. Table 2 described post-operative outcomes that didn't show any statistical significance, as well as Table 3 not showing any statistical significance between the two groups for the reoperation rates. Our study found similar intraoperative and postoperative outcomes, as well as similar complication reoperation rates between the deltoid split and the deltopec approach. However, none of these factors reached statistical significance. In addition, our study found higher union rates for the deltoid split, although this was also not statistically significant. However, we did find a significance in the time of surgery in which the deltoid split had a lesser amount of operation time compared to the deltopectoral approach. This would lead to a lower cost of surgery and time under anesthesia, which are both beneficial for the patient. We also realized that our study does have some limitations, one being that as a retrospective study, there are some inherent biases that come with this type of study, as well as a underpowered study due to our low sample size. Future studies, we would encourage actually increasing the sample size to see if this type of our findings can be generalized to the public, as well as looking at the deltoid split and deltopectoral approaches for other surgical methods besides arthroplasty. Thank you for listening. Just want to give a thank you to Dr. Hayden Schutte, Dr. Benjamin Taylor, and Dr. Sanjay Mehta for help with this project.